Cervical cancer is the leading cause of death for women in developing countries. Visual inspection with acetic acid, or VIA, is a method used in cervical cancer screening, particularly in low-resource settings like Guatemala. During this medical mission trip, NP students will use VIA testing to evaluate for potential precancerous lesions. The purpose of this presentation is to introduce students to VIA testing techniques and treatment. When conducting a VIA test, a speculum examination is done and the practitioner applies a 5% solution of acetic acid to the cervix. This is accomplished by using a large cotton-tipped applicator which is gently swirled over the surface of the cervix in a circular motion at least 3 times to ensure thorough coverage. The applicator is then held over the cervical os for at least 1 minute. This allows the acetic acid sufficient time to react with the cervical cells. Abnormal tissues will turn white when exposed to the vinegar. The cervix is then visually examined to identify any color changes. Based on the observation, the result is determined to be positive or negative for potential precancerous or cancerous lesions. VIA is a cost-effective method that doesn't require sophisticated laboratory equipment or highly specialized personnel. It is a straightforward and easy-to-learn procedure that requires minimal infrastructure. The cost of initiating and sustaining VIA is low, making it ideal for low-resource settings. VIA can be performed by trained nurses or midwives, which facilitates its implementation in rural or remote areas where doctors might not be readily available. Results from the test are immediately available, which is beneficial for timely diagnosis. The entire testing process can be completed in a single visit. VIA provides instant results, which is crucial in areas where patients might have difficulty returning for follow-up visits. VIA has potential to be integrated into primary health services, enhancing accessibility. In countries like Guatemala, cervical cancer is a significant health issue due to lack of regular screening programs. VIA allows for early detection and treatment, potentially reducing mortality rates. The infrastructure required for performing VIA includes a trained staff who understands how to apply acetic acid and recognizes the changes it causes in the cervical epithelium and how to manage the findings. A speculum is needed to access the cervix for inspection. A halogen light is used to provide intense focus illumination needed to visualize the cervix after the application of acetic acid. Large cotton-tipped swabs are used to apply the acetic acid to the cervix. They need to be large enough to cover the entire surface efficiently. A 3 to 5% acetic acid solution is placed in a small cup or bowl to be used during the procedure. A container with 0.5% chlorine solution is necessary for disinfection of the treatment area. Continued education and training for the staff to ensure quality care delivery and competency. These components ensure that VIA is performed effectively, safely, and accurately, contributing to early detection and treatment and reducing the incidence of cervical cancers. The women who will be seen in the Women's Health Clinic will complete an intake form prior to their exams. They will record their past obstetrics and gynecology history and any current gynecological complaints. Dr. Patty will record the results of the VIA exam and abnormalities seen. Patients receive a copy of their results. The squamous-columnar junction, also known as the transformation zone, is a critical area of the cervix that is assessed during VIA. This is where the squamous epithelium that lines the outer cervix and the columnar epithelium that lines the endocervical canal meet. This is the region where most cervical cancers, including their precursors, cervical intraepithelial neoplasia, or CIN, originate. The transformation zone is particularly susceptible to the persistent infection of human papillomavirus, or HPV, which can lead to precancerous changes. During VIA, the acetic acid solution applied to the cervix causes abnormal cells, particularly those that are dysplastic or precancerous, to turn white, or aceto-white as it is described, making them visible to the practitioner. These changes are most likely to occur at or around the squamo-columnar junction. In younger women, the squamo-columnar junction is usually located on the ectocervix and is easily visible during VIA. However, with age or after childbirth, the junction may move into the endocervical canal, making screening more challenging. That is why VIA must be performed by trained practitioners who can identify the junction and assess the aceto-white lesions. This slide shows the categories of VIA and how they relate to a potential cancer diagnosis. The top photo suggests possible cancer. Clinically visible ulcers, especially those that are not healing, may be a sign of malignancy. Missing anatomy can indicate advanced disease. Cauliflower-like growths are indicative of exophytic tumors. Ulcers that ooze or bleed upon touch are concerning of invasive cancer. The next photo is a positive test that would be treated with cryotherapy or thermocoagulation. Certain characteristics indicate a positive VIA test, suggesting the presence of abnormal or precancerous cells, such as opacity or scallop white lesions that are well defined and dense. Aceto-white areas, which may or may not have raised margins located at the squamo-columnar junction, are a key concern. The presence of leukoplakia and warts may also be observed, which would warrant further investigation. The bottom photo shows a negative test. There are no aceto-white lesions after the application of acetic acid. However, findings such as polyps, which are typically benign growths, cervicitis or inflammation of the cervix, or Nabothean cysts, which are mucus-filled cysts on the cervix, are generally harmless. Accurate identification of these signs can lead to early intervention and better health outcomes for women. This slide shows a photo of the cervix immediately after treatment with cryotherapy. The treated area will be pale because the freezing process causes blood vessels to constrict. After thermocoagulation, the area will look coagulated or charred due to the heat application. After treatment, the patient may experience watery and sometimes heavy discharge as the body expels the destroyed tissue. Patients are instructed to follow up in 1 year or seek medical attention sooner if heavy bleeding, persistent pain, or signs of infection develop. This slide highlights normal cervical changes. During childbearing years, the cervix varies in firmness and openness with the menstrual cycle, a visible transition zone on the ectocervix, and common benign conditions like Nabothean cysts, polyps, and ectropion, which is the everted appearance of the endocervical canal. In postmenopause, the cervix shrinks and becomes less elastic, and the transition zone may recede into the endocervical canal, making it less visible on examination. The cervix may become friable, meaning it may bleed more easily when touched. Awareness of these life stage changes is key in evaluating cervical health. This slide addresses symptomatic ectropion, a condition where the glandular cells from the inside the cervical canal spread to the outer surface of the cervix. This can lead to excessive mucus production, which might cause discomfort for the patient. It can also lead to increased susceptibility to bleeding, especially on contact or after sexual intercourse, due to the delicate nature of the glandular cells. It's important for nurse practitioners to recognize that while ectropion is typically a normal finding, when it becomes symptomatic, it may necessitate further evaluation and management to alleviate symptoms and rule out other conditions. The squamo-columnar junction, or transition zone, is crucial for cervical cancer screening. It is where the squamous and epithelial cells meet and is often where cervical cancer precursors develop. Its location can vary based on the patient's age, menstrual cycle, pregnancy, or the use of oral contraceptives. In younger women, the junction is usually found more externally on the cervix, whereas in postmenopausal women, it may recede into the endocervical canal. Hormonal changes during menstruation can shift the position of the junction. In pregnancy, the junction may be more exposed due to cervical eversion and glandular cell proliferation. Hormones and contraceptives can lead to ectropion, making the junction more visible on the ectocervix. Endocervical polyps are small benign growths on the cervical canal, often discovered during routine pelvic exams. They are more common in women over 20, especially those who've had children. In low-resource settings like rural Guatemala, awareness and early detection are key, as symptoms can be minimal, but they may include irregular menstrual bleeding or discharge. Treatment typically involves simple removal, a procedure that can be critical in preventing complications and ensuring women's health. Acetowhite lesions are key findings in cervical cancer screening, turning white after acetic acid application during VIA, indicating potential abnormal tissue. Typically located near the cervix's transformation zone, these lesions vary in size, shape, and the definition of their margins, which can hint at the severity of underlying changes. The intensity of the whiteness, ranging from faint to intense, along with the lesion's surface characteristics, smooth, uneven, or raised like cauliflower, are crucial for assessment. These features, including the presence of abnormal blood vessels or patterns, help identify potential precancerous changes. Although usually asymptomatic, the presence of acetowhite lesions may be associated with symptoms such as abnormal bleeding or discharge in cases of more advanced cervical changes. Displayed here are images of cancerous cervixes, illustrating the critical stages of cervical cancer. Notice the abnormal appearance of the cervix in each case, with erosion and invasive growths. These visual indicators are vital for early diagnosis, especially in low-resource settings where advanced diagnostic tools are scarce. Timely identification and appropriate referral can significantly improve treatment outcomes for women in these communities, underscoring the importance of thorough examinations and patient education. This image shows Candida albicans, a common yeast that causes thrush and vaginal yeast infections. In this form, it presents as white, curd-like patches on mucous membranes or skin. It's important to recognize that while Candida infections are common worldwide, they may present more frequently or severely in low-resource settings due to factors like limited healthcare access and differing hygiene practices. It's vital to diagnose and treat effectively, as well as educate patients about hygiene practices to prevent recurrence. Understanding the local context and adapting your approach to treatment and education is key to effective care in these communities. In treating yeast infections, commonly caused by Candida albicans, we have effective options. Oral treatment involves fluconazole given as a single dose of either 150 milligrams or 200 milligrams. This systemic approach is often preferred for its ease of administration and good efficacy. Alternatively, vaginal creams such as miconazole, clotrimazole, or nystatin can be used. These topical treatments are applied directly to the affected area and are effective in alleviating symptoms and eradicating the infection. It's important to note that it is not necessary to treat the partner in the case of a yeast infection, as it is not typically considered a sexually transmitted infection. This photograph illustrates a case of bacterial vaginosis, a common vaginal infection often encountered in women's healthcare, especially in low-resource settings. Bacterial vaginosis, or BV, is characterized by a disruption of the normal vaginal flora, leading to an overgrowth of certain bacteria. Clinically, it presents with symptoms like a thin grayish-white discharge and a fishy odor, particularly after sexual intercourse or during menstruation. While it's a non-sexually transmitted infection, its management is crucial in preventing potential complications such as increased susceptibility to STIs and issues during pregnancy. The practitioner's role includes diagnosing BV, understanding its treatment options, which typically involve antibiotics like metronidazole or clindamycin, and educating patients about hygiene practices to prevent recurrence. In treating BV, we primarily use antibiotics like tinidazole or metronidazole. The recommended dosage is 500 milligrams every 12 hours for a duration of 7 days. It's important to note, however, that metronidazole should not be used in the first trimester of pregnancy due to potential risk. This treatment effectively reduces symptoms and restores the normal vaginal flora. Additionally, it is not necessary to treat the sexual partner, as BV is not considered a sexually transmitted infection. This slide displays a clinical case of trichomoniasis, a common sexually transmitted infection caused by the parasite Trichomonas vaginalis, a flagellated organism enabling its motility and infection of the vaginal mucosa. In women, trichomoniasis often presents with symptoms such as a frothy yellow-green vaginal discharge with an unpleasant odor, genital redness, and itching. However, it's important to recognize that many individuals may be asymptomatic, making routine screening essential in women's healthcare, especially in low-resource settings. The practitioner's role includes accurate diagnosis, typically via wet mount microscopy, effective treatment with antimicrobials like metronidazole or tinidazole, and patient education about sexual health and prevention strategies. In Guatemala, the treatment of trichomonas is either tinidazole or metronidazole. The treatment regimen can be a single dose of 2 grams of either medication or 1 gram taken every 12 hours for 1 day, totaling 2 doses. Metronidazole is contraindicated in the first trimester of pregnancy due to potential risk. An important aspect of managing trichomonas is the simultaneous treatment of sexual partners to prevent reinfection. This photograph illustrates a chlamydia infection caused by the bacterium Chlamydia trachomatis. Chlamydia is one of the most common sexually transmitted infections and is particularly concerning due to its often asymptomatic nature. When symptoms do occur, they may include abnormal vaginal discharge, burning during urination, or bleeding between periods. The silent progression of the infection can lead to serious complications like pelvic inflammatory disease and infertility if left untreated. The practitioner's role in early detection and treatment is vital. This typically involves antibiotic therapy with azithromycin or doxycycline for the patient and her partner. Equally important is patient education on safe sexual practices and the necessity of regular screenings to prevent and control the spread of such infections in the community. Here we have the treatment protocols for chlamydia. The first-line treatment option is azithromycin, administered as a single 1 gram dose. This one-time treatment is effective and convenient, especially in settings where follow-up can be challenging. Alternatively, doxycycline, dosed at 100 milligrams twice daily for 7 days, is also effective, but is not recommended for pregnant women due to safety concerns. Sexual partners must be treated as well to prevent reinfection and further spread of the infection. Gonorrhea is a common sexually transmitted infection caused by the bacterium Neisseria gonorrhea. Gonorrhea often presents with symptoms like a yellow or greenish discharge, painful urination, and in some cases bleeding between periods. However, many individuals may not exhibit symptoms. Gonorrhea can lead to serious health complications if untreated. including pelvic inflammatory disease and infertility. The practitioner's role in early detection through testing and prompt treatment is important. Treatment typically involves the use of antibiotics like ceftriaxone, often in combination with azithromycin or doxycycline, to cover potential co-infections with chlamydia. The partner must also be treated. The recommended treatment for gonorrhea is an intramuscular injection of ceftriaxone at a dose of 250 milligrams in a single dose. This antibiotic treatment is highly effective in eliminating the infection. It's crucial to emphasize the importance of also treating the patient's sexual partner or partners, as gonorrhea can be easily transmitted and retransmitted between partners. Microscopy uses a microscope to magnify objects too small to be seen with the naked eye, such as cells and bacteria. It is the cornerstone of clinical diagnostics and significantly enhances the accuracy of identifying common vaginal infections. We will be implementing the use of a microscope and evaluating its role in increasing the competence and confidence in NP students in their evaluation of common vaginal infections. By using the microscope, practitioners can confirm diagnoses suspected through visual exams. With microscopy, the practitioner can identify clue cells, Trichomonas vaginalis, budding yeast, and pseudohyphae. This slide shows a contrast between the naked eye examination and microscopic identification of common vaginal infections. First, with bacterial vaginosis, one sees a thin grayish-white discharge, and under the microscope, clue cells, or epithelial cells coated with bacteria. These are the hallmarks of BV. Practitioners sometimes notice the absence of lactobacilli, signaling the disruption of normal vaginal flora. Next is Trichomonas with a thin, frothy, yellow or greenish discharge, and microscopically, the causative protozoan Trichomoniasis vaginalis with its distinctive flagella. The specimens must be viewed under the microscope within 10 minutes after collection to recognize the flagellate's motility. With Candida, practitioners see the distinctive white curd-like discharge and find the budding yeast cells with their unique shoe print shape or pseudohyphae with rod-like wall structures under the lens. On the right, you see an image of the normal cervix and one with normal flora under the microscope, which shows large epithelial cells and occasional red blood cells and white blood cells. In well-resourced settings, chlamydia and gonorrhea are not typically diagnosed via microscopy. However, in low-resource settings, microscopy can provide signs such as an abundance of white cells indicating infection and the absence of clue cells or yeast cells. This presentation segment focuses on specimen collection and transport to the lab area. Before applying acetic acid, the practitioner will evaluate for any abnormal presentation during the pelvic exam, such as redness, swelling, or discharge. If these signs or symptoms are present, a vaginal specimen will be collected with 2 cotton-tipped applicators. One applicator will be placed in a numbered test tube with normal saline solution for the wet prep. The other sample will be placed in the second test tube with pH paper. They will be transported to the lab area for microscopy as soon as possible. 2 students are usually in the exam room, so one student will deliver it to the lab area. Each sample will be logged into the sample log. The student will provide their initials, the test tube number, the pH value, and the suspected diagnosis based on the clinical presentation. The lab monitor will help the student make one slide with a saline swab, and another slide will be prepped with 1 drop of KOH. This step assists in differentiating fungal elements by dissolving cellular material which might obscure them. The observations will be added to the specimen log. The suspected diagnosis will be compared to the confirmed microscopic findings, bridging the gap between the initial and definitive assessments. This protocol will help ensure standardization of specimen collection and evaluation. This slide presents the standardized setup of our microscopy and exam tables. The layout ensures efficiency and maintains the integrity of our samples. The microscopy table is divided into clean and contaminated areas to prevent cross-contamination. The clean side holds the specimen log, a quick reference guide for infections, gloves, and a reserved space for extra supplies. The contaminated side has tools for sample analysis. It includes the microscope, slides, and covers for sample preparation, pipettes for precise liquid handling, a test tube rack to organize samples, a centrifuge for separating specimen components, KO8 solution for fungal testing, and pH paper for assessing the vaginal environment. The exam table will have a 0.5% chlorine solution for disinfection, toilet paper squares, and paper towels for patient cleanup, a 5% acetic solution, large swabs for VIA testing, small cotton swabs for sample collection, and a test tube rag for sample organization. Gloves, speculums, lubricant, and a halogen flashlight to assess for white lesions are also there. This standardized layout helps ensure continuity and efficiency. Please click on the link to watch the 15-minute video that provides basic instruction on preparing and examining vaginal wet preps. Thank you.